This week on the BackTable podcast.
Usually a woman wants to go to a practice where there's already another woman. So how do you get to be that first woman at the practice? I mean, those are the brave women that we need to talk to. But I think just having a culture that is flexible, that offers flexibility if someone needs to leave early or call out last minute if their kid is sick, because usually women are the first caregivers that go to those doctor appointments and get called from school, like I'm first online. Yeah, I think creating a culture at your workplace that is conducive to a woman taking the time she needs for her family or having the flexibility during maternity leave is, what's needed. But I think it is a challenge to maybe have that first woman IR join a group.
Welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. Now, a quick word from our sponsor.
RADPAD was developed by physicians for physicians. Clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RADPAD radiation protection shields for all your fluoro-guided interventions. See radpad.com for more information and contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap. And don't forget to tell them that you heard about it on the BackTable podcast.
Greetings to our esteemed IR community. Picture a future where cutting-edge interventional technologies are seamlessly integrated with world-class imaging tools that are designed to reshape procedural efficiency, enhance precision, and foster patient-centered care in interventional radiology. Because that's our vision at Varian, and we're working with partners across Siemens Healthineers to bring it to life. What sets our Imbazine and Oncozine microspheres apart? Features that enhance procedural and cost efficiency, like precise calibration and syringes that contain more microspheres per volume, which means fewer syringes per procedure. And Imbazine microspheres offer a broad spectrum of 10 sizes, each identified by distinctive colors, facilitating visualization of suspension. This streamlines the process and also minimizes the potential for errors. So experience the future of interventional radiology with Varian. Check out our innovative solutions at varian.com/interventional. Varian, a Siemens Healthineers company. We pioneer breakthroughs in healthcare for everyone, everywhere, sustainably. Now, back to the show.
My name's Ali Behetti. I'm an interventional radiologist in Tacoma, Washington. Coming to you today with Nicole Lamparello. Dr. Lamparello is an IR attending at Cornell in New York City, and she's also the program director for the IR residency programs there. Nicole, welcome to the show.
Thanks for having me, Ali. Pleasure to be here.
So our topic today is a pretty important one. It's a woman in IR topic. We're specifically going to be talking about gender disparities within IR. Nicole's done a lot of research about this, and she's happy to share some findings with us. Also, a really important topic as the proportion of women in IR is increasing every year. So let's start with your background. Could you tell me a little bit about your training and how you got to where you are today?
Sure. So I'm from New Jersey originally, and after high school, I went to Georgetown. And for medical school, I decided to come back to the Northeast, and so I went to NYU for medical school, stayed there for radiology residency, and then I trained when we still had the IR fellowship. So I went to University of Pennsylvania for my IR interventional radiology fellowship, and then after that came to Cornell for my first job as an attending and have been there ever since.
Oh, very neat. Okay, so kind of staying on the Northeast, a little bit of Mid-Atlantic. And then you started your job in Cornell in 2019, right out of fellowship?
I'm trying to remember all of the dates. Yes.
I know. Right?
I think I actually graduated Penn in 2018. So I started that fall of 2018.
Okay, very cool. Awesome. Were you excited to get back into New York after being in Pennsylvania for a while?
I loved Philly. The Eagles won the Super Bowl the year I was there, so that was pretty great. But I was happy to be back in New York. I have a big support system in New York, a lot of friends and family, so it was nice to be there.
Awesome. Yeah, and I think we'll touch on that a little bit with this episode. When did you first get interested in the topic of gender disparities in IR?
Probably right after fellowship. As a first-year attending, I had a friend and past co-resident who asked me to speak at the New Jersey Interventional Radiology Medical Student Symposium on Women in IR. So that was in 2018. And I spoke about what it was like to be a woman and really focused a lot on pregnancy and radiation exposure. So did a bunch of research on that when I was preparing that talk. And when I was looking through all of the information, that's when I came by the statistic that there's only about 8 to 9% of women IRs in the country. And that was just staggering to me. I didn't realize it was that low. So that sort of got me really interested in learning more about women in IR and why there aren't that many. And every year I kept giving the exact same talk, but just adding to it each year with the newest data. And since then, I've now given a talk about women in IR, I guess over maybe a dozen times to different medical student symposiums and the ACR and places like that.
Awesome. Tell me a little bit about the makeup of the faculty at Cornell when you got there as a young attending.
Yeah, so Cornell's a really special place from that standpoint. So I was one of 2 female IRs when I got there. But since then, we've grown tremendously. I mean, overall, I believe we have about 22 faculty, and 5 faculty are women, and we are hiring 2 more out of training this summer. So we'll be up to 7, which is a huge portion of our total faculty. So we do a really great job.
Yeah, I'm sure that didn't come naturally. I mean, I've noticed kind of also female IRs tend to gravitate towards places that have more women and female representation. And I've actually even spoken to some older female IRs who say they won't join a department unless there is already a woman there. So I think, it's something maybe we don't talk about, but yeah, something we should get into a little bit. Let's get into some of your numbers that surround your gender disparity research.
Sure. So what's very interesting is that in medical school, it's almost split 50-50. There's 50% female medical students and 50% male medical students. And these are all rough numbers, right? It might be 49-51, but it's essentially 50-50. And then when we get into diagnostic radiology residency training, we see that there's only about 28% females. And then when we keep going through to IR fellows or residents, that number is about 17%. And then when we continue through to looking at active female IR doctors, it's about 9 to 10%. And then for faculty members at academic hospitals, it's about 7%. And, in reference to other specialties, like this is extraordinarily low. So there was a study that looked at 43 different specialties in medicine, and IR was ranked number 42 out of the 43, having the least percentage of women residents and fellows. The last
I got to ask, who is 43?
Who was the last? Exactly. So that's interventional cardiology, which is the lowest today. So interventional cardiology was the last. Diagnostic radiology was 34, but we were 42, so second to last. And over the last years, we've improved tremendously. We've had a really strong influx of female trainees into the IR residency programs. So we're doing really great, but we're still not there yet.
Okay, I think that's really cool that we're training a lot more female IRs. I think that's fantastic. IR is kind of a special field, right? Because if you decide you don't want to do what you've trained in IR, you can decide to become a diagnostic radiologist pretty easly, right?
Mm-hmm.
And I think that's unique to IR, right? Because it's kind of like you can do your specialty that you really love, but if it ends up not working with your lifestyle or not being right for you, you can switch to maybe a more lifestyle friendly specialty like DR.
Mm-hmm.
So my concern as a young female IR attending is that we're training women for these private practice jobs or academic jobs that might not necessarily give them the lifestyle and the career that they want as an IR, and then they somehow or other turn into diagnostic radiologists. This is not at all what you and I were planning to talk about, I think. But have you heard this argument from other people or this point?
A little bit. I mean, it's a very interesting argument, and I think it's probably true. I mean, what it brings to my mind is JVIR just had a paper that was published, I think, just in 2024, so just a couple of months ago, about just the state of training in interventional radiology. And what it talked about is a study that looked at it wasn't just IR, but it was just women who complete residency training and how many of them stay on to be full-time doctors. And it was just showing that, especially compared to men, and again, this is in any specialty, only 22% of the women end up staying on as full-time doctors. Most became part-time. And then as you progressed through years of working, by year 6, almost 40% had dropped out of the workforce. So I think it's just like an issue, not even for interventional radiology, but I know for myself, when I was thinking about what I was going to go into, that was on my mind. I thought, I'll go into interventional radiology, but I'll have this strong DR background. And if anything ever happened to me physically, or if I decided it was too exhausting, it wasn't working well, maybe I had DR to fall back on, quote.
Sure.
I mean, I don't feel like that's in my future at all right now, but it was sort of like on my mind in the strategy of choosing a specialty.
Thanks for sharing the numbers with me about women in training and women who become IR attendings. Could you tell me a little bit about the gender gap that exists in academic leadership?
So when we look at the gender gap in leadership, it persists throughout the years. So there was a study that looked at 156 different medical institutions and looking at over 1,000 academic IR faculty. So about 132 were female, that's 14%. And in that group of female IR doctors, for assistant professors, 58%, associate professors, 16%, professors, 10%, chairs, 3%, chiefs, 6%. So you can see as you climb that academic ladder, the number of women drops off. And they also did a study that's interesting to me of program directors. And so they looked at 174 different program directors in IR residency programs and found that 12% were women. And this is true also in diagnostic radiology. But I think all of this is just important because of that idea of female visibility. So if a medical student doesn't see herself as a program director or as a professor, she might not think that she can get there, that it's possible. So having women who occupy these like very visible positions of influence and leadership can serve as role models to other women.
Yeah, I mean, representation really matters. That's something that I've started to understand more as I get farther along in my career. Any parallels to this in private practice?
I don't think there's any literature that I'm aware of about the numbers in private practice, but I would predict that the gap persists throughout private practice.
Okay, I read through your research and I would like to discuss a little bit more the concept of the minority tax. Could you explain this term to me?
Yeah, this is a concept that I just heard about in the last few years, but it's basically the idea that the burden of time and resources placed on minority persons to represent and advocate for their communities. So in our field, that's saying maybe like female faculty are disproportionately tasked at bearing the time and burden of admin efforts related to different diversity programs. And because of that, then they don't have the time, or they're prevented from investing time into different things in their career that could maybe be more valued and have more of a scholarly impact, like research or leadership roles. So it's, I think it's really true. I mean, as a female program director, anytime we have med school career night or the IR meet and greet or program director panels, like I'm asked to speak and I know I am a lot of times because they want to see someone in a leadership role that's a woman. But that then puts a lot of things on your plate that takes it away from time that you could be devoted to seeing more patients in clinic or time with your family.
Definitely. It's kind of like it's a catch-22 because you're like, oh, I want more women or I want more underrepresented minorities in here. So I have to show them that I'm out there, but it also takes away from my ability to spend time with my family and have quality time.
Mm-hmm.
Do you feel like if you bring up concerns about that the leadership is responsive?
I still am at the stage that I wouldn't bring up those concerns, I think, because I'm in that stage of yes, where I just will say yes to everything. But I think what's important at this point is to really take note of everything that you're doing and make sure that you're describing it in your CV and that you are getting, like, quote, compensated for those efforts because they are important. So if we just volunteer ourselves and do those medical student lectures but don't record them, then no one will ever notice them. And that's, at least at Cornell, I know that is important for promotion, those efforts.
Let's shift gears a little bit. I'd like to understand a little bit more about why physician workforce diversity is important.
Sure. So there's a lot of evidence that diversity among healthcare professionals increases access to care for underserved populations and improves patient satisfaction. So bridging the gap, the gender gap, is really favorable for patient outcomes. There have been studies, one study that looked at mortality and readmission rates when comparing Medicare patients that are cared for by female internists compared to male internists, and showed a decrease with those by female internists. And then another study of female IRs showed that female IRs spent more time evaluating and managing patients and clinical visits compared to the male counterparts. So this is especially pertinent in IR when we're striving to be a more clinically based specialty and emphasizing longitudinal care. It's important for us to have women and other minorities in IR, right? So this doesn't even, this sort of my talk that I give isn't just about women, but it's about people of color and sexual minorities and first-generation college students. Patients often want to go to providers or doctors that look like them and that they're familiar with. So if we want to have IR just, prosper, we need to increase our access to all of these different patient populations.
That's fantastic. That's a great way to put that. Do you ever feel as a female IR that you get pigeonholed into treating mainly female-specific disorders or diseases?
Sure. Yep. I think it's sort of the thing, like if you're a female IR, you're going to do uterine artery embolization. That's the thing, right? I think I do. I actually like it, and I've grown to love that patient population, so it works for me. But I do think that is, potentially a problem. I mean, they've done studies looking at SIR and the topics that women are asked to present on. And the topics are like stereotypically female topics. So pediatrics, women's health, education, economics, not really like PD or portal hypertension.
Yeah. Maybe that'll change as the trend in female IRs increase, branch out. Speaking of that, tell me a little bit more about the upward trend of female IR trainees.
Sure. I don't know if you're like free to show that graph if you want.
We'll put it in our show notes.
So we looked at data from 2017 to 2021, and it showed that interventional radiology had the almost highest year-over-year growth in women, in the percentage of women, compared to any other subspecialty. And these are surgical subspecialties compared to interventional cardiology. So there was about a 65% year-over-year growth from 2017 to 2021. However, although we were surpassed by interventional cardiology, overall we have more women than them. So they have about 15% of trainees that are women going into their field, and we have 22%, the most recent data. So this is great. It's a great
that's really
trend.
Encouraging. Yeah. What do you think has really spurred the growth?
I think mostly it's spurred by medical student outreach, because now with the new training paradigm, the integrated residency, we're having medical students apply directly from medical school. And so we have to reach them earlier. So these symposiums that a lot of the medical students have, IR rotations, IR electives, the interest groups, having different simulation exercises. So these hands-on workshops are really important for medical students who want some kind of hands-on specialty, offering shadowing in medical schools, and then research opportunities. So I think all of those at the institution level are really, really important. And then nationally, SIR has done a really great job. A lot of other subspecialties look up to SIR for all the work they do with their RFS, resident fellow section. We have a women's and an IR committee that is also great. It has a lot of networking opportunities for women at all of the annual meetings. They have events. And so I think all of that's really powerful and important for increasing early medical student exposure.
Let's talk a little bit about the barriers to gender equity. What do you see as the primary obstacle to gender disparity?
So I think, just as we said, that why IR has had an increase in percentage of women over the last 5 years is increased exposure. I think one of the barriers is not enough exposure. So we're still not doing enough. There's still medical students who don't know about the field. Some of them find out their last year of training, so they don't have enough time to put their application together.
How did you find out about IR?
I knew in medical school from like one of those dinner lectures. So when you're a medical student, you can get free dinner if you attend a lecture. And I think the radiology interest group did one with an interventional radiologist who was like very animated, and he brought in like equipment and it was just so funny and happy. And I thought, I'm like, this guy is pretty cool and I've never heard about this. And so I just kept looking into it. So going into graduating medical school, I already knew about IR, but went into diagnostic radiology sort of for what we talked about before. Like I knew DR would be like a nice lifestyle field, but I knew I was interested in a surgical subspecialty. So I thought that I could do a couple more years in diagnostic radiology until I figured out if I really wanted to commit to IR. And then after my first rotation of my PGY 2-year, I knew that that was what I was going to go into. So then I just put my head down from there on out. So I think I was lucky because I knew pretty early in medical school, but I hear a lot from students that they don't know. And it's really the symposium that they attended that changed their mind, or that IR interest group dinner lecture that changed their mind. So these are all really important touch points. And sometimes I think we take them for granted when we speak at these symposiums, that we just take for granted like how powerful our lectures are to opening their eyes to this field, because they're usually not exposed during their normal clinical rotations.
Yeah, I mean, like how many like regular hospital people don't even know what IR does? Like it's like a black box, right?
Totally.
People go down to IR, they do something, and then they come back, and then voila, they're fixed, you know?
Exactly. I thought it was interesting that I read a study about medical student exposure and how less than 6% of medical students do an IR rotation. And that's despite almost 60% saying they want a hands-on field. So they're not able to do the rotations or not. And then when they were asked about what IR does, to your point, most of them didn't know the kinds of procedures they do, when to consult IR. So they had like limited knowledge really what it was. So how are they supposed to decide that that's what they want to apply to out of the gate?
Tell me about some other obstacles to achieving gender parity.
So there's been a number of studies that have looked at, or surveys really, of women to see what are their concerns and barriers to going to the field. And they've been asking faculty, but also medical students. And the most common concerns are work-family life balance, radiation exposure, extended work hours, the length of training, so being perceived as being pretty long, male-dominated work environment, and effective pregnancy on training and in practice. And then, so those are like the main concerns that women find, but what's really not talked about that much, I think, is mentorship and lack of representation of self, which we discussed a little earlier. I think that not seeing women at the podium or in the IR suite sends a message to a female medical student about what it requires to be successful in that field, and they might not go into the field if they're not seeing that at their own hospital or their own medical school.
Yeah, it's very true. Can you tell me a little bit about the response from our national and international organizations to address this problem?
So there have been a few surveys of medical students and female IRs to look at what exactly is a barrier to going to the field. SIR conducted a survey of 143 U.S. medical students, and they identified different areas that were barriers to going into IR. So that included work-related exposure to radiation, length of training, work-life balance, and lack of female role models. And 43% said that they were discouraged from becoming an IR. And over 50% of the women surveyed said that they reported that they do the majority of household responsibilities at home. And so that was a hindrance for them determining or picking a field like IR. There was another study, a CIRSE online questionnaire, which had the best response rate to date for any CIRSE online questionnaire, looking about the challenges that women have for going into IR. And most of the respondents said that the main concerns, again, were similar to what the medical students said: work-family life balance, risks of radiation exposure, and male-dominated work environment. So we see the same topics just being repeated. And I think, again, going back to having role models, if you have a female role model to talk to, they can address these concerns. You can ask them about radiation exposure. I mean, I don't know about you, but when I was a medical student, that was on my mind because that's what I sort of was told. And now at the stage I'm at, I don't think about that. I mean, I practice safe radiation techniques. Like I wear my lead, I like collimate, I use last image save, like all of that stuff. But I don't think about what the radiation is doing to my body because I know better now. When you're in training and you don't have anyone to talk to about that, you think, you're going to get cancer if you do IR. So maybe I shouldn't be doing it, or I can't be pregnant and do IR. I was pregnant twice and did cases to like the day before I delivered, wearing lead in long angio cases. And so it's definitely possible. I have healthy babies that, and I did a bunch of research on the effects of radiation. And I know this talk is not really on that and it can get very physics heavy, but it would be so difficult to ever get enough radiation exposure that you would have any effects on the fetus. It would have to be orders of magnitude more than we receive. So the safety precautions that we take as IRs today make it safe to practice a full career and to have a child.
Let's talk a little bit about outsourcing. Let's talk about merits and downfalls of outsourcing a lot of the stuff in your household to outside folks.
So that's sort of probably an under talked about, but also popular topic is outsourcing. But I think it sort of matters what we define as outsourcing. So I'm a proponent of outsourcing the things that allow you to then spend more time with your family. So not necessarily outsourcing the childcare, but like, I'll have someone clean my house, mow my lawn. Now that a number of my kids are in school more, I have my nanny help me with grocery shopping. Or I know friends that use, Fresh Direct or like any of those websites that will bring food to your house, but just things that you don't, aren't necessarily excited about to do on your own, but then free up time. Because, the fact is there's 24 hours in a day. So anytime you say yes to something, you're inevitably saying no to something else. Unless you decide that you're going to multitask. And I think especially this generation now, we're all on Zoom, but you're firing emails out, at the same time. You're trying to like do two things at once. So you're not always dedicated to doing what you're doing. So it's just important. When I sort of realized that, I listened to a podcast actually that talked about that, how you can't do everything. Like there just physically is not amount of time. So if I decide I'm doing something for work, then I'm taking away either time for myself or my family. So it's just important for me then, and I probably don't even do it enough, but trying to allow myself sort of the grace that I don't need to like make the cupcakes for school or, do all the handmade stuff. One of the funny stories I have is when my son was in preschool in the city, there was like a bake sale day. And I came home from work and I stayed up like very late making these cookies and like wrapping them individually for the bake sale. And it was like a big deal for me to like be the one that brought my kid to school that day and brought him with the cookies. So I was like the mom that was present, and every single other person had store-bought items except me. And so this was like typical like Upper East Side New York with moms that like already knew that they weren't going to bake themselves. But I thought all these moms were like baking stuff and I had to do it too. And so now I know that I'm not doing that ever again. But I think those are the things that you can maybe try to take the burden off yourself so that you have more time for other things, the things that matter to you.
So there's a saying, you can do anything, but you can't do everything. And that totally is like true, especially if you're a female professional. And you're going to want to do everything because we're all like a little type A if we're female IRs. But it's just, you got to pick your battles, right?
Yeah, totally.
Have you found anything that's like not worth outsourcing, would you say?
I love doing all the doctor appointment stuff with my kids. I still am the one that I organize like all the play dates, I do all the camp scheduling. No, so like I think anything regarding my kids is not outsourced. even the haircuts, like I'm upset that I'm not at the haircut today with my boys because they're not going to have it done right. I know I'm going to have to take them back next week to have it done the way I want it done. Yeah, I don't know. Is there anything that you're thinking of?
I mean, just when my kids are like really, really young, like I have a 3-year-old and a 1-year-old right now, and just like being present around them, like during the daytime, not like coming home and being like, oh, I got to cook dinner and like I got to get all the lunches ready, and like just like having time where I'm just sitting with them, present, like playing with them has been just such a life changer for me. Like I don't have to do I would say like we're all very good at multitasking, probably. I mean, that's like what being an intern is, right? It's like checking stuff off your check boxes. But avoiding that and just focusing in on doing one thing with my kids and showing them that they're the most important thing to me right now has just been a big change for us. I also notice now that I work part-time that my kids' behavior is just a lot better when I'm around a lot more. Yeah.
I can see that because the need of attention that my kids have, like when I come through the door, it's like they're just all over me because I guess they're missing me and not seeing me. So that is hard. And then they fight with each other to have my attention. So I can see that for sure. But that is, I guess, what I try to do with the, quote, outsourcing is to have someone to make their lunches, to do their laundry, so that like when I have nights and weekends, that's all that I'm doing is just like being with them. And it also helps to know the leadership in your practice or your department, because we have a strong emphasis on well-being at Cornell, and it comes from the top down, and we have every week non-clinical days and so much flexibility in our schedule. So I was big old lunch mom this week, and I get to go to all the things. I coached the T-ball team last year, so I definitely feel like I am able to do all of it, but never at the same time, as you said. So I never feel like there's a balance. There's times when it's too much work and too much, not too much family, but usually the balance is. It's hard to achieve, but I think at the end of the day, I mean,
dude, that's the thing. Like, too much family is like an actual thing. Like,
I can't say that on a recorded podcast.
Yeah, I know, right? They're gonna dig this up in 18 years and listen to it. But no, I mean, like sometimes you just don't want to be home with a 3-year-old and a 1-year-old all day. You like want to talk to another adult, right? And no, so that's like a thing too. And I think it's like. The important thing for me is just figuring out like how you want to spend your time, right? So for some women, it might be, I want to spend it doing cases. I want to spend it in the lab. If that job like existed where I could just do cases all day, that sounds amazing. But I also really try to remember that my kids are only going to be small for like a few years, and I really need to maximize my time with them. The last part of your presentation really focused on the lack of female visibility at plenary sessions. I have the feeling that you have very strong feelings about this.
I just found it really interesting when I learned that, and some of this data is a little old. I think the study I was looking at was digging up some SIR data from 2017 and 2015 to 2017. But what was just so interesting was that only 4 women in SIR held nearly a third, or like 32% of all the coordinating positions at the meeting. And there was about, at all of the podium sessions in 2015, 7% were women. In 2017, it jumped to 13%, but 0 women spoke at the plenary sessions. And I'm not sure like what it's been most recently, but I do think that just sends this message of leadership diversity and creates a void of role models. And as we sort of talked about earlier, the subject matter when a woman did speak at the meeting was on the stereotypically female areas. So we talked about like the women's health or education, pediatrics. Only, I think in this study, 0% of women spoke on PAD, 2% spoke on venous interventions. So I think it's just interesting. And I do believe it's improved since that study, and I see a lot of female visibility now, but there's a lot of room to improve. Looking back, when I was interested in IR as a medical student and a resident, I had strong female role models. My program director, when I was a radiology resident early in my residency, was like a woman, was Divya Sridhar, and she was revamping and creating the integrated residency curriculum at that time, and was like very passionate about it. And she's like an amazing technical IR and, very energetic. So she was a great role model. And even someone a year above me in training was going into IR, and now she's a very well-known pediatric IR, Cheryl Tulin-Silver. I had I've been blessed with a lot of strong female role models. And I think that during training, it didn't really cross my mind that I was really entering this male-dominated field. I just knew that I liked it. It wasn't until after training, when I was really digging up the numbers and doing these presentations on women IR and being asked to speak on it, did I really realize how I was just lucky, probably, that I had these role models that encouraged me to go into the field. And some women don't have that.
You were shielded, man. I'm telling you, that's really lucky. That's a really good, that's a great situation. But like you said, it's getting better.
Mm-hmm, mm-hmm.
They're trying their best, I think. Okay, what can like male mentors do to try and encourage more women? Like, let's say you're a guy and you're in practice, an IR doctor, and you're like, oh man, I really want to recruit more women to this practice. What are the steps that I can take?
So I think that's a really great question. Because as you talked about earlier, like usually a woman wants to go to a practice where there's already another woman. So how do you get to be that first woman at the practice? I mean, those are the brave women that we need to talk to, those pioneers. But I think just having a culture that is flexible, that offers flexibility if someone needs to leave early and or call out last minute if their kid is sick, because usually women are the first caregivers that go to those doctor's appointments and get called from school. Like, I'm first online. Actually, what's interesting, this is like a little tidbit. My son's in preschool, and I'm learning the last 3 weeks that I am not being called by his principal anymore. He hit his head this week. I wasn't called. Last week, he had a stomach ache. I wasn't called. They're calling my nanny, and the principal tells my nanny, I don't try Nicole because she's never available. So she's not even trying to call me. She's going straight to the nanny. So of course I had to.
So how does that
head on. It makes me feel annoyed because one of the times I was working from home that day, so I was totally available. My phone was on me, and I don't even believe there's that many times when I was trying to be reached and wasn't available. But there's this perception from that principal that I'm a doctor and I work in the city, which is. I live in New Jersey right now, but work in New York. So I live pretty far away from the hospital. So she probably thinks I'm just not reachable. And so she doesn't call me first. It definitely hurts, but I know that I'm always around. So it's more that I just need to set that principle straight, which I did.
You tell them.
But yeah, I think creating a culture at your workplace that is conducive to a woman taking the time she needs for her family or having the flexibility during maternity leave is what's needed. But I think it is a challenge to maybe have that first woman IR join a group.
Yeah, that's a real question. I get when I go to meetings or talk to other private practice groups, they ask me, we are seeing like an influx of female patients who want to see a female provider. How do we recruit a female IR to this group? I personally, on this side of the fence, I think one of the biggest things is to offer flexible schedules, part-time positions, and just some of the things that I've seen. Like you said, the women are usually the primary caregiver or the person to be called from school or has to take a random day off, and basically having structures in place to support that if it needs to happen. As well as giving them their schedule well in advance so that they can make all their plans for childcare.
That's a big one. Having a schedule in advance is huge.
Yeah. Mm-hmm. Yeah. As we get more and more women through the pipeline and there's just the pool of IR doctors tends to be more female, I think the practices will start to change and start to realize what they need to do, especially if they want to recruit and retain female IRs.
Exactly. I agree.
Well, this has been really fun talk. Sorry. We got off course a little bit here and there, but is there anything else that you'd want to tell our audience in regards to gender disparity in IR?
I just want to say that while women still make up a small proportion of IR trainees and IR doctors, we've really come a long way. This last class has about 22% women. So those are huge strides. And I think we just have to continue to increase exposure in medical school and increase visibility of females in the podium and in the angio suite. And I think that will go a long way to increasing or, breaking up gender gap.
Nicole, thanks so much for being on the show.
Thanks so much for having me, Allie. Appreciate it.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck, Sabine Dong,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and Digital Marketing led by Brian Schmitz.
Social Media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.